Thank you, Dr. Umar. It's been a lively session about all the common shock OT procedures in cornea practice. Am I audible and can visible?
Very clear, very clear. Your
Yeah, yeah.
lines are
Thanks, Umar. So my topic here today is pterygium with fibrin glue. So in the next 8 minutes, I'll just take you through the salient features in the management of the pterygium. No financial interest in the mention of any products during the course of this talk. So the most important aspects one needs to look into when you're handling a pterygium is to look at the amount of preoperative inflammation here. The surgical aspects which deal with the management of the pterygium, the pterygium head avulsion, the subconjunctival tissue management of the during the surgery, application of cautery or mitomycin when required, and the bare sclera closure, the postoperative management. One aspect you need to remember when you're handling recurrent pterygiums is always remember to assess the ocular motility, because this can get affected if the patient has had an extensive surgery prior and which has affected the medial rectus as well. So that's one aspect. Of course, all the preoperative aspects on counseling and explanation to the patient also needs to be adequately covered. One factor which we usually do fail to note is the grading of the pterygium. The morphological grading system of T1, T2, T3 is either atrophic, intermediate, or fleshy. And depending upon the extent of pterygium, it's grade 1, 2, or 3. Whether it's crossed the limbus, it's 1. When it's midway between limbus and the pupillary margin, it's 2. And when it's crossed the pupillary margin, it's grade 3. So it's always good to document the severity grade of the pterygium you're dealing with. And when it's recurrent pterygiums, it's again into 4 grades. When one is when you do not see much of a recurrence following a surgery. 2, when the episcleral vessels are still visible. 3, you have an overlying fibrovascular tissue reaching in, and 4, the fibrovascular tissue is invaded into the cornea. This helps you to prognosticate and help out with the patient and tell them what is going to be the post-surgical recurrence rate in when you are managing pterygiums here. Again, important factors is when you're managing pterygium along with cataract, which general ophthalmologists commonly ask. So if the corneal involvement is less than 2 millimeters with minimal astigmatism, then some would prefer to do a simultaneous surgery. If it is more than 2 millimeters with significant astigmatism, sequential procedure handling the pterygium first, waiting for topography stabilization, which could vary from anywhere between 1 to 3 months, followed by the cataract surgery. When there's extensive corneal involvement with pupillary axis being covered, then you would need stage procedures like a keyhole or a lamellar keratoplasty along with the pterygium excision before you plan a cataract intervention. Other aspects which you need to consider is application of mitomycin in recurrent pterygiums, the role of amniotic membranes if you're looking at recurrent or extensive pterygiums. Again, consideration of a technique of conjunctival autograft versus a conjunctival limbal autograft in the management of primary and recurrent pterygiums here. Not going to delve into the fine aspects due to the lack of time, so I'll just run you through one patient with a minimal pterygium who was insistent on having it removed because of cosmetic purposes here. Simple small ones like this in young individuals. Then one aspect you need to take care of is the proper counseling, looking at the how fleshy or atrophic the pterygium is, which is going to be a pointer towards its recurrence, and the preoperative ocular surface inflammation, which needs to be controlled beforehand. Commonly, a simple pterygiorrhexis, as you saw in this particular patient, would be enough rather than going and doing a dissection in this patient. And remember, the tissue resected should be as minimal as possible. And once you have dealt with the pterygium and removed the subconjunctival fibrotic tissue, as you saw earlier, measure it up. And I always, when using glue, I tend to give about a 10% larger size, because in glue you cannot stretch out. But when you're using sutures, you could probably use the same size because it helps in stretching here. And as you saw here, inject between the space, the subconjunctival and the tenons, and that helps to lift out your conjunctival autograft. You can use a blunt forceps or a cotton spud as you are everting out, and to avoid a buttonholing during the fashioning of the donor graft here. Many now prefer to avoid the superior region, supratemporal region, and inferior grafts can be harvested. The glue is in two components, as was already explained to you by Dr. Paris. You have a fibrin component and a thrombin component. The fibrin has the clottable factors along with the fibronectin and aprotinin, which needs to be mixed. And the thrombin component, you can lay them out separately, or you could do it together as was shown in here. What you also need to remember is managing postoperative complications. You can have a pyogenic granuloma, fibrotic granulomas, severe recurrences like this you can have here. Common mistakes or common factors which one needs to be concerned about or cautious when you're operating is never leave a bare sclera here. And a bare sclera with intensive topical therapy is going to result in intensive melt and infection. Again, excessive cautery is a word of caution. You do not need to cauterize too much on the scleral bed because the pathology lies in the subconjunctival degenerative tissue here. So cauterizing on the backside of the conjunctiva after identifying the bleeding vessels will give you better results in achieving hemostasis of the patient. Do not do too much needless keratectomy on the cornea, which is going to increase your astigmatism. Then be careful for infections. If they are inflamed cervices teeth, take care of the inflammation. A conjunctival swab preoperatively will also help in such patients here. And look at systemic conditions, do not miss them. These are again a few complications which can occur, subgraft hemorrhage here, a granulomatous reaction here in this graft. This is something which we commonly see when we have too much of excessive cautery or surgically induced necrosis of the sclera, or you have following an extensive mitomycin infection. I think I'll stop here and we can take questions if there are any. Thank you.